Again, meeting materials are posted on the QHOC website, and for meeting participants specifically, you would have received them in your email box from Jennifer Bowen. QHOC website is QHOC, Google that, plus OHA, and you'll easily find it on the good old web. Hi, Jeannie. We have about a minute and we can probably get going. Looks like everyone's kind of joining here shortly. Hi, Roger.
Good morning. Can you hear me?
I'm just going to say hi to everybody who joins on camera. Hi, David. Oh, David and I were just talking about joining on camera.
Good morning.
Okay, Jeannie, I think we could probably go ahead and start if you'd like.
Sounds good.
Okay, hi, I'm Lisa Bowie, Quality Improvement Director. We have Dr. Jeannie Savage, our QHOC Medical Director Chair, and Dr. Don Montner, OHA Medicaid Medical Director. We will get this QHOC September meeting going. Hi, Marcy. Basically, if you go on camera, I'm just going to say hello to everybody. Let's go ahead and just do a couple of tips for meeting participation. Please remain muted when not speaking. You have that Zoom icon of the microphone. If your muting and unmuting button isn't working, please use the *6 function on your actual phone. That could be why it's not working. Under the reactions button, you have the raise hand function. And if you wouldn't mind when you're speaking to say your name and your organization. Next slide. Again, I just went over a few of those tips, but on the menu bar, you see those actual where they are. There's also closed captioning so that you can use the chat function on the bottom and or closed caption for live transcriptions. Next slide. Today's agenda, we've got a full one. We are going to have Roger Citron with the pharmacy and therapeutics update, then we'll go straight into HERC. I'm sure Ariel has some more COVID codes. Seems like it's an ongoing conversation. We'll have a brief stretch break. Then we're going to have Nathan Roberts from our Health Systems Division Medicaid Policy Unit talk about EPSDT, which then dovetails directly into durable medical equipment conversation. Then Veronica Guerrera from our Quality Assurance Division section will come and talk about our return denials. And then I will speak specifically in regards to Oregon Medicaid Quality Strategy, Qualified Direct Payment Program, specifically, possibly, I think Tom Wonderber is also on. He's the Qualified Direct Payment Program lead as well. Then we'll have lunch. And in the afternoon session, we have the Transformation Quality Strategy Peer Learning Session. So for the whole afternoon, CCOs will be presenting on their TQS projects, and in breakout session forums, we'll be learning about each other's TQS projects. Next slide. Are there any questions or announcements before we go into P&T, Jeannie or Dawn?
Nope, no questions from me.
Okay, Dawn.
Only a good morning. Welcome back as the summer winds down. This has been an amazing
weekend. And I appreciate all the work that the CCOs and KeyPro on behalf of Fee for Service are doing to get air purifiers, air conditioners out and support our communities as they are facing climate-related catastrophes, wildfires, and the rest. So thank you for the work you're doing. I'm glad you're here.
And on that note, please stay safe, everyone, in your communities, and I will turn it over to Roger.
Good morning. Can you hear me okay? Fantastic. Roger Citron, he, him pronouns. I'm the director of the Drug Use Research and Management Program. I see on my slide here, Mackenzie Carroll. I don't know who that is, but they got added to my slide, so welcome. Next slide, please. So I'm here to report on the August P&T committee meeting. The P&T committee also serves as a DUR board, and we last met on August 4th. The recommendations were sent to the director of the OHA and approved and posted on August 9th. The link here will take you to the P&T webpage on the OHA's website. You can see the recordings of the meetings, the minutes, and the recommendations that were approved. Next slide. One of the topics we had were the estrogen class. We hadn't looked at it in a while, so we went and reviewed the clinical evidence. There was nothing compelling to make changes to the PDL based on that evidence. We went into executive session and made a few agents preferred. So you can see those for both the oral, topical, and vaginal agents. The link at the bottom of the page goes to our searchable web application where you can type in drug names, see the PDL status, see if we have any dedicated PA criteria. It also gives you links to all of the documents we've ever produced. So the drug class reviews, newsletters, etc. Next slide. We also reviewed the PCSK9, they were the inhibitors. We changed the name to the modulators. We were looking particularly at a new drug evaluation for inclisiran. We recommended making that or maintaining it as non-preferred. Any agent that comes to market in a PDL class is non-preferred till we review it. So we maintain this one as non-preferred. And we also proposed some PA criteria to limit its use to its FDA-approved indication, which requires a trial of a couple of other agents that have evidence of cardiovascular risk reduction. We went into executive session again and made no other changes to the PDL. The link at the bottom of this page will actually take you to that dedicated PA criteria. Next slide. We also reviewed the oral thyroid hormone class. We elected to add this class to the PDL, so that then lets us designate preferred and non-preferred agents, and the committee recommended just making levothyroxine preferred, all the other agents non-preferred. When we do that, we also have some discussions about people that are on existing therapy, so we'll be grandfathering those members. Generally, we do that for a year, but we'll also reach out to providers for an educational opportunity to let them know that levothyroxine really has good evidence, and that's going to be our preferred agent. Next slide. We reviewed the oral beta blocker classes. Based on the evidence, we designated acebutolol as non-preferred. Recommendation was to make hemangiol open access for children up to 6 months old. The committee felt that that should be sufficient time to open that access, but by then that should be by 6 months they won't need it anymore. After comparative cost consideration and executive session, we made a couple agents. So propranolol long-acting 24-hour capsules, generic oral propranolol solution, and nadolol tablets preferred. Next slide. We reviewed the nasal allergy inhaler class. Again, no changes were recommended based on the clinical evidence, but we elected to remove the PA requirement for preferred intranasal allergy products for children up to their 21st birthday. And this aligns with EPSDT that we'll be talking about a little bit later with Nathan. So again, because of that and the cost effectiveness of those, it's just a minor change we made to the criteria. We looked at the rest of the class in executive session. No other changes were recommended to the PDL. Again, once again, here's a link to the PA criteria specifically for those intranasal allergy drugs. Next slide. We also reviewed the sedative class. No changes based on the clinical evidence, kind of a recurring theme. But the Mental Health Clinical Advisory Group did give some recommendations to the P&T committee to facilitate benzodiazepine tapers, and so that members might need a sedative while they're on that tapering process. And so we updated the PA criteria to reflect that recommendation. We also looked again at pricing in executive session and no other changes were made. But again, this is a link to that specific PA criteria so you can see how we folded in that recommendation from the Mental Health Clinical Advisory Group. Next slide. And that's it for the substance of the meeting. The next meeting we're going to have with the P&T committee is slated for October 6th. We just posted the agenda and all the final documents. Those are available here on our website. There's a link at the bottom. If you haven't already done so, I think most of you have, we invite you to subscribe to our listserv. You'll get notification when we post documents and when we publish our newsletters. Next slide. And hire, I'm a broken record. We're still looking for physicians. I think we're down to one now, but we're still looking for interested physicians, MD or DO that are actively practicing that might be interested in being considered for appointment to the P&T committee. They're 3-year terms, and I'd be happy to answer any questions about the committee if you're so inclined to entertain that idea. And with that, I'll see if there are any questions. You can next slide, please. All right, I got us a little ahead of schedule. Thank you.
Lisa, you're on mute.
Oh, for those positions, Roger, that you've been recruiting for, I take it that you just haven't received any applications?
Right, I think we just received one, but exactly, just physicians
So like
that are
okay.
just interested in, everybody's busy, right? And
Yeah.
it's not a
And it's a
minor
commitment.
commitment. You know, we meet every other month, but it's for a whole afternoon. So, 1 to 5 o'clock, but it's important work, right? It really helps guide the fee-for-service program and our PDL and PA criteria. So really welcome anybody that might be interested in doing the important volunteer work. Thank you.
Thank you. Ariel, I think you're up next.
Sure. All right. Well, my name's Ariel Smith. I am the medical director for the Health Evidence Review Commission, which helps determine coverage policy for our OHP members. So hopefully you've had a chance to look at our minutes and everything. I will kind of go through the highlights of our last few meetings. Next slide, please. We always have this. It used to be the COVID slides. I guess it should be COVID slides again. So these are 8 new codes. The first 6 should be, or actually, I guess the first 2 and the 5th and 6th should be open for you all. These are the new bivalent boosters. The FDA, CDC, and the Western States Collaborative all approved the new bivalent Moderna and Pfizer boosters for anyone over 12 for Pfizer or over 18 for Moderna. There still is no EUA for the younger groups, so those codes are currently published but not open or active. So just make sure that the 12 and up monovalent booster or bivalent boosters are open for your patients. I believe they are already available and being administered. Next slide. So the HERC met in August. We went through the 2023 ICD-10 code placement. There should be a spreadsheet with all of the recommended placements on our website if you need them for your billing systems. No real surprises if you looked at the meeting materials. There really wasn't a lot of, I don't think there were any changes from what was recommended. We updated our tympanostomy tube guideline, which allows some additional high-risk kids to qualify for PE tubes based on the new otolaryngology guidelines. We also allow adenoidectomy with PE tube placement. This is a change in the ENT guidelines to try to reduce multiple anesthesias events for kiddos. We reviewed TMJ, which is currently not covered, and did not move it above the current funding line, so it continues to be non-covered. We looked at conduct disorder. This was previously a covered line until the legislature moved the funding line up in 2012, we with the recommendation of our behavioral health advisory group, will make this a covered diagnosis effective January 1st. Insomnia was also moved to a covered line, but this is effective January 1st, 2024. And we added a new guideline that specified that sedative hypnotic medications are only to be covered if a patient is currently having CBT therapy or previously in the last year had a trial of CBT therapy. And these medications are limited to 1 month because of concerns for habituation. We added microsatellite instability testing, which is now kind of a standard of care for colon cancer testing. Next slide, please. We modified our scoliosis guideline that had previously had an age limit of 18. We just changed it to adolescent idiopathic scoliosis at the recommendation of surgeons. Sometimes these conditions are actually requiring surgery at slightly higher ages, like 20 or 21. We looked at canaloplasty for treatment of glaucoma and added coverage. We looked at our coverage guidance for high-frequency chest wall oscillation devices, also known as chest vests. We added coverage for cystic fibrosis, bronchiectasis, and pulmonary complications of neuromuscular disease with a new guideline that essentially, there are different limitations for each category, but essentially there has to have been a trial of other therapies, or the other therapies like chest physical therapy is not available because of lack of caregiver or other indication. Next slide. And again, all of our August minutes are available on our website. They were also in your packet. If you have any questions or want to see any of the specific discussions, the specific guideline wording, etc. Our behavioral health advisory group met last week. They recommended adding additional codes for residential therapy for anxiety. We currently cover long-term residential therapy, but not short or medium term. We clarified our acupuncture guideline that for substance use disorder, that in order to get a substance use disorder, acupuncture for substance use disorder, the patient has to be in some type of documented additional treatment. It doesn't have to necessarily be a formal treatment program. We looked at prioritization of personality disorders, but did not add any, or did not recommend adding any of these, of the personality disorders that are currently below the covered line to a covered line. Similarly, we looked at somatization disorder and did not recommend adding coverage. We also looked at the clubhouse model for chronic mental health disorders. BHAP was a bit conflicted because they thought these are good peer led services, but they are not, there's no formal, there's no licensed person to provide a formal diagnosis or to formally bill. We have set up some discussions with our colleagues in Washington who currently use this model to see how it works there. So there's some more research we need to do before this topic actually comes to the HERC. The other 4 topics will definitely be discussed at our October HERC meeting, and the clubhouse model may or may not be, depending on sort of the answers to a lot of the BHAP questions that hopefully we can get from our colleagues. Next slide, please. Oh, and again, the BHAP minutes or highlights are available on our website if you want to take a look at those. Our oral health advisory panel is set to meet on October 4th. We will look at the 2023 CDT codes for recommended placement. There's also a proposal to kind of clarify or slightly expand when we do dental implant removals. We currently don't cover that, or we have limited coverage for dental implant placement, but we felt we should liberalize the removal for those that are causing infection or problems. We're also looking at labial frenectomy, which is also known as lip tie. We looked at this in 2017, which is 5 years ago. So it's been 5 years. So we're looking at it again. The initial staff recommendation is to not add coverage, but again, this will be, we will discuss this with the whole OHAP group to see what their input is. So this These recommendations are likely to be discussed at the November VBBS and HERC meetings because the next VBS meeting is a couple days after. Next slide, please. So our next VBBS HERC meeting is October 6th, just a couple days after that OHAT meeting. We have several things on the agenda. We've been looking at the inflammatory skin disease guideline. It currently has very explicit criteria for when we cover various medications and other treatments for psoriasis and eczema. We've been working with dermatologists and with our P&T folks, and we are going to make significant changes to this guideline for psoriasis. The recommendation is to essentially have everything be first line because we only cover severe disease. And for eczema, there's going to be most things would be first line. A couple would be only when they fail other therapies. And there was one medication that the dermatologist thought should be sort of last resort. We are going to look at QALYs, which are quality adjusted life year. These are somewhat controversial ways of looking at the cost effectiveness of a treatment. We've been asked to look at this by several groups that deal with folks with disabilities. Currently, the HERC does not really use QALYs, although we do use cost effectiveness. We're going to, however, create a formal policy, basically saying that we may include studies that have QALYs or other resources that have QALYs, but we're not going to use QALYs specifically in any of our decision making. We are looking at having a statement of intent for public health emergencies. This would mirror the requirements for commercial insurance based on the Oregon law, and it would sort of just expand that to also apply to Medicaid programs. So essentially, if the public health the person in charge of public health at OHA declares a public health emergency, either in a local or statewide, we would cover all indicated prophylactic and treatments. Congenital foot deformities, this may or may not be on the agenda. I'm having trouble getting podiatrists to give me input. So if you have any podiatrists that you want to send my way, please do so. We're going to look at our hydrocele coverage, which essentially would just reiterate that we don't cover this for adults. Autologous chondrocyte implantation may or may not be coming. We may not make any changes. It may not come. CPAP, which is the sleep testing for obstructive sleep apnea. We've been asked to look at when repeat studies are necessary, and we've been working with sleep specialists. Essentially, we're going to have just propose a short addition to our guideline that would say repeat studies would be covered if a person has significant change in body weight, more than 10% BMI, either gaining or losing, they've had some type of surgery or other intervention, or are having significant worsening of their comorbidities. And this would only be for adults. We heard from the sleep experts that children have very individual needs, so that would still need an individual review. Next slide, please. Other items on the October agenda, we're looking at our human growth hormone treatment guideline. We may actually recommend just deleting it and leaving coverage up to P&T, although that's still a little bit up in the air. We're doing a very comprehensive review of our solid organ transplant lines. And we are working with OHA staff who are writing new rules. Our current rules are really, really woefully out of date, and we are revising them. And then basically trying to simplify our transplant lines. For example, like renal failure, chronic renal failure would basically be the indication for kidney transplant, and liver failure would be the indication for liver transplant. There would also be sort of one new large transplant guideline to replace our kind of current piecemeal guidelines. We're looking at congenital ear anomalies, and I'm trying to get a pediatric ENT to weigh in on that. Most likely there will be no change in coverage. We currently cover ear anomalies that result in hearing issues. And then other things that are below the line in our below the line review would be some orthopedic lines with no recommendations really to change that. Genital urinary conditions with no treatment required. The recommendation is just a little bit of housekeeping. A couple of conditions that require some workup would be added to the diagnostic workup file. And then the congenital ear anomalies, as you see there. And then there's congenital knee anomalies, which is part of the orthopedic lines, which currently have no recommended changes. Next slide. So those are our current VBBS. Again, it's going to be October 6th, which is Thursday, obviously. And again, all of you are welcome to attend as guests. If you have any specific input, you're welcome to look at the meeting materials when they come out a week ahead of time, or send me an email or something if you want any input on any specific topic. Our evidence-based guidelines subcommittee is going to be, it met last week actually, and discussed bariatric surgery. The upshot of that, that meeting was that we are going to take a deeper dive into the evidence behind coverage for people with a BMI of 30 to 35 and for adolescents. And the current coverage of BMI over 40, BMI over 35 with comorbidities will probably continue. And then there was discussion of our continuous blood glucose monitoring scoping statement that will be probably discussed this winter at some point. Also on our future agenda for EBGS is biomarkers for cancer, because that's a very rapidly moving field and our coverage guidance is out of date. Next slide, please. And also for EBGS, again, if you have any topics that you think should go through the coverage guidance process, please send them to HERC.info. And also if you have any topics that you want VBS or HERC to take up, send them to me or to the HERC.info. Next slide. And just, you've seen this a couple times now, the HERC.info email has changed. It is now oha.oregon.gov. So please change that. The grace period on the old email is coming to an end. So make sure you have the new email in your email system. The current emails for myself, Amy Cantor, Jason, and Liz are all the same currently, but we have heard that we are also going to be changing to the oha.oregon.gov in January. So we will let you know when that is finalized. Any questions, input? I see Doug has a hand up. Anyone else?
Yeah, you've got a question. So we'll go to Doug first, and then I'll tee up the other one for you.
Okay.
Ariel, some time ago when we were discussing the waiver, we had EPSDT. And so the statement of intent number 4 was revised, but you had, beyond the general statement, you had indicated that HERC was going to be doing a lot of review of various things and related to that, and give us advice before January.
Yeah, so we've been doing a lot of it. You heard a little bit of that with this, what's coming in October and what we talked about in August. So we have done, we have actually gone through every line that's below the funding line, and we have either moved diagnoses like conduct disorder to a covered line, or have reiterated that whatever condition generally doesn't need treatment. If something is below the current funding line and you have a specific case with someone under 21, you are still by EPSDT, and this you will see these slides coming up ad nauseum with the whole EPSDT discussion, but there's still an obligation to at least consider things on a case-by-case basis, even if it is below the current funding line. Does that answer your question?
Yes, that's helpful, Ariel. I appreciate it. So it's kind of a two-prong approach, and update the guidelines individually when you're available, but anything under 21, and that's kind of what we've been doing already because rather than just have this January cutoff, we know it's coming, so let's just start incorporating it into what we're doing on a regular basis, and it's a lot easier that way.
Dawn, did you have any more input? I see you, I guess you just put your thumb up that you agree.
We're about to give a whole talk on this. Thank you.
Yeah.
Oh, I'm sorry, Don. Okay.
But we've tried to reduce the workload by moving some things above the line so that they will just pair and you don't have to review them. Lisa, there was another question.
Yep. For inflammatory skin disease guideline, can Ariel address if there is a plan to specifically review for kids with regard to SOI4?
SLI4. Oh, statement of intent 4. So the current skin disease guideline really only applies to severe skin disease, and it would be covered, and it kind of, with the modifications, most treatments would be covered as sort of first line. For mild or moderate, those are still below the funding line. So if a child has perhaps just mild eczema, it would still need a review, because if that child, for example, is so itchy they can't attend school, or it's on, they are whatever the whatever the argument is from the provider, you would still need to at least look at it. If it involves face or hands, it's already considered severe. So that's a lot of the kids who might have psychosocial problems attending school because of the visible lesions. But if a child is too itchy or too uncomfortable or can't concentrate at school, or that type of thing, that would have to be an individual review.
Thank you. Kat?
So along those lines, Ariel, for the inflammatory disease guideline, is there a plan to specifically, might there be edits specific to kids, or is that still going to be an individual review basis? So just wondering, the upcoming guideline review, if you plan to rewrite how kids are addressed or not.
So the current draft, as it's been done, applies to everyone. But we have been working with pediatric dermatologists, and some of the changes are actually really because of their input. For example, there was a couple of drugs that we required as sort of early, either first or second line, that are actually pretty toxic to growing people, and that they were pretty appalled that we would require that for a 3 or 4-year-old child, where it might really cause toxicity. So we actually removed some things. We also removed systemic steroids. We left it in as an option, but we removed it as a requirement because of its impact on the growth of children. So there's some things that are in there that are because of pediatric indications and need, but it's not going to explicitly say, for adults you can do this, but not for kids, that kind of thing. It's kind of still a global guideline. Does that answer your question?
Yeah, thanks.
Bhavesh?
Yeah, hi Ariel. Thank you for your presentation. The question I had was around, I've seen increasingly specialists start to put down something like, this could affect this child at school, or it could affect their ability to participate in activities at school. And it's not like that the child already has some issues at school, but they're using that as a potential, as a reason for asking for coverage. And I wondered if the HRC would want to make comment on, the generalism that's being thrown out there by some specialists versus actually having an issue at school before we would allow for coverage, and whether we should just be covering all of this just because a specialist feels like it might, or whether we should react to an actual effect on a particular child or not.
Dawn, before I say anything, do you want to jump in? Dawn doesn't want to jump in.
That's a big, complicated and hard question. A really good one, Bhavesh. Thank you for raising it. I don't have a thoughtful response at this time, but I'd sure like to go back and think about it, and I would welcome thoughts here.
I mean, my initial thought is this is really a medical appropriateness. So if you have a case where it seems pretty obvious in your medical judgment, completely not treating X would result in this kid having a permanent limp or inability to use a knee or something, so they can't participate in sports. That might be more obvious than a specialist saying, if we don't treat this, there might be a problem. I think you still have medical necessity and sort of your medical judgment, as long as you are willing to go back and re-review if you find more. But I think this is probably more along the lines of the rulemaking process that I think OHA is working on. Mark, I think you had your hand up, and then Holly Jo.
Hi, Ariel. Thank you for all your help and all my emails. Question on the adolescent scoliosis. If we do get the comment that it started in adolescence and now the patient is 35 and needs to have a scoliosis surgery, would that be considered if the orthopedic uses the term adolescent scoliosis, but now we're 30, 40, or even older? Thoughts?
So what we were told by our orthopedic specialist was that this sort of adolescent idiopathic is a separate entity from adult degenerative. So they shouldn't be using that diagnosis unless it really, so, if a kid had serious scoliosis and maybe they had surgery and they need a repeat, or maybe they, you would have to kind of look at it to see. So adult degenerative scoliosis is not intended for coverage. It doesn't really respond well to surgery. Yeah, a 35-year-old would get you in this odd case of maybe they had some adolescent changes, but it's degenerated over time. And so what is it? So that's a gray area. We were told by specialists that they rarely or if ever use that diagnosis for people over 25-ish. That the specific case that came to our attention was a 21-year-old. And especially in males, they might still have some growth or change at that age, but at 35, they should have stopped all growth and kind of been at a stable point for a while. So sorry, that's not the most helpful, but.
No, and that was that orthopedic doctor who said we use this term for 25, 30-year-olds because it started and not covering doesn't make sense. So I agree, it's a gray area because it progresses, and we will see those cases in the mid-20s, early 30s.
Okay, Holly Jo?
Yeah, Ariel, again, I appreciate your efforts on all of this and helping us understand, but it is the more that you can give us guidance, and OHA has got to understand that for every well-intended as this may be, we're all already seeing ways that people are trying to take advantage of it in ways that Bhavesh clearly delineated. And it's not rare, unfortunately. And so we need as much guidance and clarity and uniformity as possible around all of these issues, because it comes down to our clinical opinion against somebody else's. That's going to be really difficult. And so I think that if we second opinions or I don't know how we're going to try to get around all of this, but coming down to, do we trust the chart note versus not, or what terminology is used or not? I mean, this is really becoming difficult, and we just really need to all stay on the same page and understand what our goals are here. And I think most of us do understand, but that this is not just an opening of the floodgates, and not every single tiny little thing necessarily needs to be or should be or can be treated. And I think we've got to try to help educate everybody on both sides of the fence. You know, what does this really mean, and what is truly the intent here? We gotta keep using medical necessity, but we need to understand, everybody needs to understand what that means.
So we have a half-hour presentation coming up, just for your
Okay, great. Thank you.
all about EPSDT, and there hopefully will be some answers, but if you guys are raising really good questions that I think a lot of folks here at OHA might need to sit with for a little while as we kind of come up with all of our internal rules, etc. Dawn, do you have any other input there other than?
Let's do the EPSDT talk and then see what questions remain and take it from there.
Yeah, and just as a, you'll hear the whole EPSDT talk. After that, if you still have any specific questions about like something that the HERT can really just act on, like, hey, we're seeing this specific problem a lot with kids, send that to us and we can try to, maybe if it, it has evidence, we can move it into a funded area so you don't have to do these reviews. Any other questions? Again, our next meeting is October 6th. OHAP is coming up that first week in October. My only other ask of any of you is, if you hear rumors or get a copy of the CPT codes, please let me know like right away. We're still waiting on them, and the more time we have to look at them, the better. So that would make me forever in your debt if you could send them to me early. Any other specific HERT questions? I think we were supposed to do the EPSDT talk at 11. Do we want to do that a little earlier, or just?
I think we'll probably, even though Nathan was able to hop on, I think we'll probably just take a little longer break. But I will actually, David, did you talk at the medical directors about meth a little bit at all? Did you happen to bring that up this morning?
No, we did not.
Oh, okay. So with T and DME, which DME is somewhat related to the EPSDT. I mean, as Dawn's nodding. So they're kind of intertwined, at least for the durable medical equipment part of the presentation. So I would suggest, Jeannie and Dawn, that we just take a little bit longer break, unless anyone else has any ideas.
We can't just start it early, or I don't understand why we can't start it earlier.
Because it's like a 20-minute slide deck.
Right, but rather than take a long, I don't understand why. I'm sorry, I got confused. Why are we taking a longer break?
We start the presentation at 11 versus starting you can start the presentation, but then you'd either have a late break, or you can take your break now and come back at 11.
I got it. Thank you. Sorry.
So you can go take your break, come back at 11, and just do the whole thing in one swoop, EPSDT and discussion, and not have a break, not just go continuous. So everyone go take a stretch break, go fill up your coffee, go fill up your tea, get some water, hydrate, stretch, and come back at 11. Nathan, hopefully you were listening. Everybody's ready for you. because they've got questions about kiddos and services. So,
Let's
have
do it at
fun.
11. It's going to be good.
You don't get a break, Nathan. You get to go review your slides. No, and we'll see everyone right back here promptly at 11. Jennifer, if you wouldn't mind just advance to the break slide, and we'll see everyone back at 11. And we'll start right back there with EPSDT. Thank you.
Good morning, Lisa. It looks like you might be speaking, but I think you might still be muted.
Nope, but it is 11 o'clock, so we should probably start. Look at you, right on time there, Dawn. Nathan, you're back. Great. Let's go ahead and start. Nathan, you have the floor. You can let Jennifer know when to advance slides. And welcome back for those who have come back from break. We will begin with the EPSDT presentation with Nathan Roberts. Go ahead and introduce yourself, Nathan.
Yes, thank you so much, Lisa. My name is Nathan Roberts, and I am a manager with the Oregon Health Authority in Health Systems Division with the policy team that's working on Medicaid policy. Happy to be here with my colleague Dawn Mountainer, who'll introduce herself in just a moment, to present about EPSDT and update everyone on progress and what is happening in that space. And I'm going to hand it to Dawn to introduce herself. People should know you by now, right? You're a regular attendee at QHOC.
Sometimes I make it. Good morning, all. Dawn Mountainer, she, her, a white woman, long dark hair, black top, and I serve as the Medicaid medical director for OHA. And Nathan and I are going to tag team on this presentation. Early and periodic screening, diagnostic and treatments, or EPSDT, has been in the news quite a lot recently, and for some good reasons, and then for some reasons that that may or may not reflect a consistent and systematic array of issues, because we do quite a lot of EPSDT work through OHP, and we'll talk about that. Next slide, please, Jennifer. As many of you are aware, the early and periodic screening, diagnostic, and treatment benefit provides comprehensive and preventive healthcare services for children under age 21 who are enrolled in Medicaid, and states are required to provide those comprehensive services. Next slide, please. These are the ways that the feds define EPSD and T, and for the most part, as you all know, we do a lot of this work. Next slide, please. There is a myth that Oregon doesn't do EPSDT. OHP has been covering most EPSDT related services since its inception. It is most, and it's not all. And those that we have not been covering have been coming under some increased scrutiny, and there are some very good reasons for us to make this change. But as you know, we have covered most of those services. The waiver allows us at this time to restrict coverage for treatment services identified during an EPSDT screening for individuals above age 1, which means greater than 1, less than 21, to the extent that such services are below the line in the unfunded region of our prioritized list. Next slide, please. So EPSDT in Oregon currently covers all of these things. None of these things have ever been waived. Comprehensive physical exams, health and developmental history, screening, preventive lab tests, immunizations, etc. Screenings for vision, hearing, oral, dental health, and interperiodic screening. That is to say, in between the regularly scheduled screenings, if something comes up, a family can get an evaluation. Next slide, please. These are also within the currently covered services array, from behavioral health to case management, speech, language, hearing, occupational and physical therapy, etc. I won't read the slide, but it's the vast majority of EPSDT related services that Oregon has always provided, and you provide through your CCOs and through the fee-for-service OHP plan. Now, the changes that are coming are going to be delineated. Importantly, the final determination, a final denial, will need to be made on a case-by-case basis. This was always the rule. Next slide, please. It has become clear that the current waiver around EPSDT is problematic, especially for children and youth with disabilities, especially for rare conditions, but it's problematic. That's why it's being addressed. And we appreciate the attention and communications from the public and from our advocates around that. Next slide, please. For these reasons, OHA is not seeking renewal of the waiver, which means that the unfunded region of the prioritized list will not be able to service as an administrative reason to deny a service. There was a communication from OHA to partners in the media on February 8th of 2022 that delineates this decision. Next slide, please. As Ariel just mentioned, HERC is completing a review of unfunded services, those that fall in the unfunded region of the prioritized list, with the unique needs of children and youth in mind, and most remaining EPSDT services are being moved above the funding line. And for those that remain unfunded or below the line, the requirement will be, again, that medical necessity be determined on a case-by-case basis for denials for children and youth. Next slide, please. Some examples of items that had previously been found in the unfunded region but are now found in the funded region are some specific examples here: tendon and ligament injuries, conduct disorders. Actually, tendon and ligament injuries will be going into effect as of 10/1. Conduct disorder and impulse disorders will be effective 1/1 of 23. Forgive the language, please. Handicapping malocclusion, or HCM, which is a kind of orthodontia that helps to correct very severe malocclusion or misalignment of the jaws to allow eating and speech development. It's not intended for cosmetic orthodontia. It's intended to address the more severe forms of misalignment that will support the medical necessity implied by handicapping malocclusion. as of the 1st of January of this year, as noted by some of my colleagues earlier in this conversation, the statement of intent number 4 through the Health Evidence Review Committee was updated to include treatments supporting growth, development, and participation in school. And this new report that the specialists are using potential impact on participation in school is something that we're going to have to think about in terms of how we operationalize this change. Next slide, please. So the coverage is expanding with this change. And utilization controls can still be used for items that remain below the line. However, established limits on services must be tentative. That is to say, a final denial of a prior authorization or of coverage must be based on case-by-case review of medical necessity and medical appropriateness. That is to say, it can't be an administrative rule that we don't cover that because it's below the line or because it falls in an unfunded region. It has to be after individual review of the case. Next slide, please. As you are, many of you are likely aware, the decision draft of the CCO contract, the one on the basis of which the current CCOs decide whether or not they wish to proceed to recontract with OHA. That draft of the contract reflects these EPSDT requirements, and the CCO model member handbook has been updated. The changes in MMIS that have to be made are being worked on as we speak. And Nathan, if you have anything more on that, I offer you to step in here.
Yeah, thanks, Dawn. This fee-for-service system change, I don't think will largely impact the CCOs. One of the oddities with our claims adjudication system, the functionality in our MMIS, is that the below the funding line is coded in there in such a way that we can't make exceptions to it. And so when we do make exceptions, the fee does, I think this is only a fee-for-service challenge, but when we do grant exceptions, as we are required now under statement of intent 4, and we will be under EPSDT, we have to walk those through manually. And so the system change that we are seeking will get us an ability to authorize and then have a claim auto adjudicate. So that's the piece that we're working on, but largely I don't think this item will impact CCOs.
Thank you. Next slide, please. The guidance that you have already expressed a desire to have is on its way. The draft document is being worked up now. I expect it to be in your hands soon, by the end of the month at the latest. I hesitate to say words like that are so definitive, but it's on its way, and that is an opener for a conversation. It doesn't have to stay like it is when it's submitted to you for document development. There's a dialogue to have there as the guidance gets established, as you have the experience that you have in the interface, and useful perspective to help design a document and a policy that works. And we can provide webinars and office hours as needed. The goal is to have the guidance finalized and posted in early November. ahead of that January 23 implementation date. If there are other ways for us to support you, please do make those clear. But we look forward to your participation, review, questions, feedback before the guidance document is finalized. Next slide, please. Again, the website is coming through. Here's the communications plan, and this is a request for input and dialogue as well. The program change memo will be coming out in the CCO weekly update. This is your QHOC notification about it, number next, and we'll have some more of those. The Ops Collaborative will be tomorrow, and there will be a contracts and compliance meeting on September 27th. Please make it clear to us if there are other ways that communicating about this would be helpful. This is, again, a request for dialogue. Next slide, please. For the remaining communications out to members, the member handbook, providers via Provider Matters, still looking for better ways to communicate with providers. CCOs have much better ways to communicate with providers many times, so look forward to your collaboration in sharing this information with our providers. Pharmacy newsletter, advocates, the general public, and then ongoing community engagement and dialogue. One of the shifts that you may have witnessed in the last couple of years of pandemic learnings is OHA's interest in establishing ongoing dialogue with members, families, providers, and partners. We've always had QHOC, at least since I showed up at OHA now a couple of years ago. But effective dialogue hasn't always been supported between OHA and any, much less all, of those interested parties. So we are still working on what this looks like, and we know that a lot of folks on this call have expertise on how to do a better job, both of communicating, of developing the policy itself, and as outcome on serving Oregon's communities. One area where feedback and input cannot influence changes is when it conflicts with federal requirements for how we implement EPSDT. So a lot of things are changeable, but there are a lot of things that are not for that reason as well. Next slide, please. So a recap on what is changing. No EPSDT requirements will be waived as of January 1, 2023. For items below the line, established limits on services must be tentative. Final denial decisions must be based on case-by-case review of medical necessity and medical appropriateness. And the reason for that final denial cannot be solely that the service is unfunded or below the line as an administrative decision without clinical review. Next slide, please. We know that it will take time. We're doing our best to get ahead of it and provide guidance and have these dialogues. As I think it was, maybe it was Doug who said, we've already been working to implement through statement of intent for and putting into place structures that support the medical evaluation to prevent administrative level denials. But we know that not every system and process can be updated on this timeline. So we're putting this framework in place, and we will continually evaluate and improve the quality of our implementation of EPSDT in dialogue with those who are using and applying the benefit, including CCOs. That's where QI comes in. Nathan, would you like to step in there?
I think you articulated it very well. Inviting dialogue today about those things that are immediately in front of us for January 1, but this slide is really about also inviting dialogue throughout all 2023 and forward, when we're in more of a QI mode and really trying to refine and make this benefit work well for families, for CCOs, for all of us. So really acknowledging that there will need to be refinements and discussion and changes in 2023 as well.
Thank you. Next slide, please. Now, there is a lot of information on these slides, far more than we're going to be able to talk through during this presentation, but now you have the information in the form of the slides, and you can bring questions back, whatever we need to address in more detail. The CCO responsibilities. Nathan, I'd like to invite you to step in here if you'd like, and do the next few slides.
Yeah, so one of the federal requirements with EPSDT is that members are well informed and of this benefit. And so this slide is really addressing that is a responsibility, since CCOs administer the health plan for children, that shifts, or that we are in partnership with you on delivering. So this slide is detailing out some of the pieces that we will need to make sure are properly in place for the children's benefit in the Oregon Health Plan to really meet those federal requirements that members are well informed about their benefits. Some of this isn't new or surprising, right? We have done a pretty good job and have pretty good expectations, but we'll want all the CCOs to take a look at how you're doing with that, with this benefit in mind from that lens.
Perfect. Next slide, please. Here's some specific ones that we wanted to name. The ensuring transportation assistance is received, scheduling assistance is received. Be sure that the periodicity schedule is being reviewed. Again, these are all built into existing expectations. Next slide, please. Notices of denials, right to hearings, 10 days of notice. Again, existing requirements that we will try to support implementation of. Next slide, please. The hearing rights and continued coverage, the in-plan grievance and appeal process, as well as the hearings through the state, the timely resolution of complaints, including within 3 working days when there is serious health jeopardy. Next slide, please. OHA responsibilities include, and this is for quality and process improvement over time. Lisa Bowie, I'm glad you're on the line here. Statewide program support, webpage and materials on EPSDT, communications ensured for fee-for-service members, compliance across CCOs and fee-for-service, tribal consultation, as well as RAC processes, and we'll be working up some provider education as well as doing our own reporting. Next slide, please. These reflect most of the same requirements as for CCOs, as well as coordination and review of cases that rise through the EPSDT, through the hearings process, excuse me. censoring equity, this is going to be a journey for all of us. Next slide, please. We wanted to share some learnings, and I realize that we are running to the end of our time here. We wanted to share some of our learnings from fee-for-service as of the update of Statement of Intent 4 to cover the services that will improve a child's ability to grow, develop, or participate in school. Next slide, please. With that, we have been reviewing clinical reviews, providing clinical reviews on every potential denial for members less than 21 years of age since January 1. And as of 8/17, those have been 39 cases, the grand majority of those for DME. As always, the better the provider documentation, the easier the case is to review. But the numbers haven't been off the charts, except for the DME work, which is a separate but deeply related body of work. As you may be aware, the medical management committee is where our medical directors provide physician level consideration for the nurse reviewers' cases. Next slide, please. The rest of these slides are in great measure reference slides for you with links to the federal and Oregon resources. Next slide, please. There are the federal ones. Next slide. Plain language, trying to make sure that we're censoring equity again. And the next slide, please. If you have questions, you can reach us and the EPSDT analyst team here. And as you all know, dialogue with collaborators and partners, including families and members, helps us to do a better job of meeting their needs and center equity. So thank you for your ongoing participation and collaboration with us as you provide us with the information we need to do a better job of serving Oregon's communities. Happy to take any questions. Well, Nathan, it looks like we did it. Thanks, everybody. Sounds good.
Well, you did it, Don, but yes, thank you.
It was clear as mud. Sorry, I'm starting to get a migraine, everyone. Nathan, are you?
I mean, I'll make a recap statement. I hope people are really hyper focused right now on January 1 and the changes, right? We have to have that pathway for making those individual case considerations, right? You can still have utilization management, but at the end of the day, we can't have systems that where a final upon appeal decision is that's not covered. For children, it always has to be, if we're going to deny it, that's not medically appropriate, right? So that is a process change, system flows change, thinking change, because for a very, very long time that was acceptable. We were able to stand on, it's below the line, it's not covered. And now on appeal, effective January 1, just like Statement of Intent 4, you've got to have a different justification for those denials. The other piece, which is probably less of a challenge, but several things, the HERC has already moved above the line. Some are coming on October and some are coming January 1. So make sure we're ready to cover those children's services that have moved above the line through the HERCS process. Those are the two biggies for January 1. Most of the other work, continue improvement, refinement, getting the systems in place is 2023 work. And there will be lots more dialogue about those things.
Thank you, Nathan. Laura?
Hi, thanks, Nathan and Dawn. I completely agree with you, Nathan, about having the systems in place. However, I think for the CCOs and DCOs, one of our things that we're having angst about is the handicap and malocclusion. And we're 4 months away from January, and we just haven't had a ton of communication around how this benefit is going to be implemented. And then departure of the dental director just kind of threw everything into the fire. So I think if I could just impress upon all of you that we've got to have communication about how we're going to implement this benefit.
Thank you, Laura.
I appreciate that a lot. And we're racing to get things on track. And with that, I'll hand the mic back to Lisa for our next speaker. Thanks, all.
Lisa, we're not hearing you if you're talking.
That was a double mute. Nathan, did you cover DME?
Lisa, can you remind me? I don't remember which part of the DME I was supposed to cover. I'm so sorry.
You're asking me when I have a migraine, man.
I didn't say I'd be fair or kind. So is it perhaps an update about car seats as a
Dawn,
DME or
car
supply?
seat. Jeannie Savage, car seat, the DME. Dawn.
There is a big undertaking to figure out how DME, including car seats, are going to need to be, how that coverage needs guidance. But I don't have anything specific for this.
And just for the other medical directors, when we refer to car seats, we're not talking about your typical, thing you go over and buy at Target. These are the medical car seats for, special needs people who may not have body tone or something like that.
Okay, great.
Dawn, you'd mentioned you wanted a conversation on durable medical equipment, and during our agenda setting call, you and Jeannie were talking about durable medical equipment, and it was the example you provided was car seats, and it might have been a combined conversation between the HERC and Nathan, and then in that fleshing out, this is my memory again with the half a migraine. It was tagged that Nathan was going to be the point person. Now, if you can go back in your memory of this conversation during our agenda setting call about specifically in regards to the
I can
conversation.
Lisa. Yeah, this
Which
is Jeannie. This is Jeannie. I can. Sorry to interrupt. So there was a specific question around an FDA approval issue. So in statement intent 4, around EPSDT funding. It was a question of FDA approval cannot be utilized in the evaluation of DME supplies. And then the example was car seats. They're not FDA evaluated. So the question, I think the question for Nathan was, how are we, is that all medical? I think it was, is that all medical necessity? How are we looking at these decisions?
Thank you. So that is the current state, and we think that there's enough interest in these that we probably want to move it differently. So I guess I'll restate the current state. The benefit, it's generally not covered because of that DME rule that you were citing that says medical supplies must be FDA evaluated, and many of these adapted car seats are not regulated by the FDA, and so categorically they're out. Now with statement of intent 4 and EPSDT, then that puts them in, well, we can't simply say it's not covered. So then they all the requests have to be reviewed for today for statement of intent 4 and in the future for EPSDT, and that the approval or denial will be based on the child's medical appropriateness, right? A determination there. We think we can do better than that. We think that we can probably put in some standards that would allow much easier processing for the majority of these. I think there are some criteria where it's everyone be in pretty much agreement that those types are types of car seats and types of health conditions, the low tone that Ariel mentioned, are, don't need a lot of consideration, should be covered. And so that is the body of work that we are wanting to take up. We I don't have really a date for when we'll have that one resolved. The staff that we had working on it, we allowed her to retire, darn it. And so you may not see a lot of movement on this one until really next year, but it is an area that we think with some changes in the rule, we could make it so that not as many of these have to go to through that exceptions process, which is more work for the for us, the CCOs, the payers, and more work for the families and the providers. Holly Jo.
Yeah, so I thought I understood, and now I'm just more confused. So maybe we need to take car seats as a separate issue from DME, or we have to remember that there is a component of medical necessity involved here. Not every child needs us to pay for a car seat, or unless that's something you're going to adjust our rates for, and that's a whole different process. Or if that's something we're going to cover, fine, but we need criteria, and I think we also need to understand that there are safety issues involved. Car seats are not, the approval process and the evaluation process of car seats is certainly way out of my bailiwick.
Yeah.
But there is a huge component of safety and harm here as well. So I hope that we're thinking about all those aspects of that.
Thank you, Holly Jo. Yes, and I think that I would agree. We probably should name this as its own separate issue, and work on it that way. And really, I think we're coming from exactly the same place, that there is then heightened now with EPSDT obligation for us to make these determinations, and a lack of guidance. And so I completely on the same page with you that we do need to put in the time and do the work on this. We don't believe that EPSDT requires it, nor is it a good policy that we would buy all of the infant car seats that anyone could ever want. That isn't our business, but the child who's 11 and has very low muscle tone from cerebral palsy or that type of thing and needs an adapted car seat. I think with EPSDT, we'll probably have a difficult time saying that isn't a medically necessary item. So I think that's the kind of guidance and criteria that we're hoping to get to, and move it from the place where it is now, where it kind of is on each medical director to figure out. So.
No, Nathan, that sounds great, and I appreciate that. But I'd also hope that we think about on that, because the car seats in and of themselves are in a category by themselves, are really difficult to determine that whole safety and not harming issue. And so if there's a way that OHA can identify some body of authorization or some credentialing or some way, some way that we as medical directors can understand that someone has looked at this device and has said it is safe as we can expect it to be, because you can imagine we get requests for everything under the sun that can be Googled.
Right.
And we have a hard time determining, is that really safe enough?
Yeah.
Thank you.
Yes, thank you.
The other DME things that have been coming up at MMC a lot are different types of seating arrangements, different things to go with wheelchairs, or and different sleeping kinds of arrangements. So those might all need some consideration.
Nathan, I think that's just for you to kind of make note as other devices to consider when thinking about car seats. It's not just car seats, is what Ariel's saying, I think.
Yeah, I think some beds, adapted beds, and other seating have certainly are in a similar category.
And I'm not saying strollers, but whatever Ariel was just speaking to. So it's sleeping, moving devices, and then car seats. So all of those continuum of supportive devices for individuals that may need something special.
These are not conventional car seats. I think that's one of the terms that showed up, because there's a real easy case to make that a conventional car seat is medically necessary and appropriate for every child. But that's not what we're talking about here. So that distinction is what is the case that needs to be made for medical necessity and appropriateness with a diagnosis that makes sense to require specialized equipment. So we'll work on getting some more guidance out for that. Thanks for your questions, everybody standing by.
Thank you for that refresher, Jeannie and Dawn, as to what the durable medical equipment conversation was about. Thank you, Nathan and Ariel, for providing the context of the actual need of it. And we will remember, Jeannie and I, and to bring Nathan back as the Health Systems Division and Fee-for-Service team moves the work forward. Again, ETA and staffing to be determined on that. I was checking in, since we are running a little bit ahead schedule. It looks like overturned denial staffing, Veronica is not available quite yet. So I'm gonna flip ahead, and we're gonna do the quality strategy, qualified direct payment topic ahead. So Jennifer, if you wouldn't mind moving those slides up, that'd be great. Oh, you are awesome, you already did. So Tom Wonderborough, are you on? Hopefully you are still, Tom. Great, if you wouldn't mind introducing yourself.
Hi, it's Tom Wonderborough. I'm a policy analyst with the Health Systems Division of the Oregon Health Authority. I'm helping support Lisa in the quality strategy work, and also to get the approval for our qualified directed payment programs from our partners at CMS.
Great, thank you. As a reminder, I'm Lisa Bowie. I go by she, her, hers. I am the Quality Improvement Director, and I help kind of from a strategy side of quality for OHA. I will be presenting on the quality strategy, and then I'm assisting again Tom on the Qualified Direct Payment Program. Let's go ahead and go next slide. Just a good level set of where we've talked about this before. Tom and I presented here at QHOC a couple different times for the Qualified Direct Payment Program, otherwise known as QDP. In 2022, we're updating the quality strategy for the QDP. We are actively, as an agency, talking, and this should be no surprise, about the 1115 waiver. And as the 1115 waiver negotiations continue, then the Medicaid quality strategy for Oregon will be updated yet again. But it will be after we finish the 1115 waiver negotiations, because how you evaluate the 1115 waiver and how you monitor, i.e. the quality strategy, has to wait until you actually, land with CMS on the 1115 waiver. So that's kind of that. So we look at that into 2023, which is post waiver approval. And then we will, again, the Qualified Direct Payment Programs is an annual preprint application process. And so that will be again in 2023. And then also in 2023, we'll start looking at alignment with our long-term services, our 1915 waivers. And then in 2024, we're looking at, again, the assumption that there, again, it's all contingent with CMS, but the quality component of the Health Equity Quality Metrics Committee, which is a key portion in regards to how we plan on doing the metrics, incentive quality pool metric portion of Medicaid. That's proposed in the 1115 waiver. If in fact that is approved with CMS in these negotiations, then we can see some reconciliation and update to the quality strategy program for Medicaid in that 2024 version. Next slide. So the Qualified Direct Payment Program at a glance. Basically in 2022, Oregon received approval from CMS to administer these programs. There's 4 different ones. There's a rural hospital, a diagnosis-related hospital group program, a public academic medical center, so Oregon's for OHSU, and then a ground emergency medical transportation. So each one of these 4 are different applications that we submit from OHA to CMS, and we negotiate with CMS on these. It is likely that we'll be submitting a 5th one, which will be specifically around the behavioral health arena. Next slide. Since April, we've been going, when I say we, Tom and I have been going out to various different committees, inclusive of QHOC. We've gone to the Health Equity Committee, the Medicaid Advisory Committee, and we've been asking for hospital care and the direct, the QDP program, what kind of quality areas are their concerns, and what kind of quality components do we need to work on? And what we heard so far is these 3 kind of themes: cultural linguistic services, ensuring interpretation services at the time of care; access to care, ensuring access and quality to care in rural hospitals for all patient demographics, OG; and coordination of services with partners, DHS, primary care, transportation, CCOs, and community. Next slide. So here's the results of that. So what I'm showing at this time is the QDP potential reported goals and objectives. I know it's a lot, so I'm going to walk you through it. Basically, on the first column is the QDP type. So like I said, there's 4 types at this point. The behavioral health is proposed, so I did not include that at this time. The second column is the quality strategy goal. That's the Medicaid quality strategy. That's the state quality strategy. That is not the CCO's TQS. That's the state of Oregon's Medicaid quality strategy. There's the quality strategy goal and objective. And then the 4th column is the QDP potential evaluation measure. So what we heard from CMS, when we submitted last year's 2021 preprint applications for each one of these QDPs, is CMS basically told the state of Oregon, OHA, thou shalt have connection points to QDPs to your quality strategy. Is pretty much where do these QDPs line up to your quality strategy? Like, what's the through points? This is the connection point. When we looked at the QDPs and went out to the communities, i.e. the engagement meetings from April, inclusive of QHOC, we listened to the community, and this is the proposed connection points to the quality strategy, inclusive of goals and objectives, and the potential measures that we'd use to evaluate those. You notice that they're by QDP type, and there's consistency across each types of QDPs. And then you'll notice there's some non-bold ones in the OHSU Public Academic Medical Center, because we're still working with OHSU on some of the let's call it the non-clinical or the consistent ones across the the hospital arenas, but the more the academic teaching side ones, we're waiting to work with OHSU on those proposed ones as well. So you'll notice those ones are not bolded, as in we're still working with OHSU on those particular measures. But what you have on the second column is the quality strategy goal. What you'll see is alignment with the 1115 waiver, or alignment with what's known as Healthier Oregon, otherwise known as the State Health Improvement Plan, the SHIP, otherwise known as Healthier Oregon. So for instance, let's just take the first row, which is the rural QDP, ensure quality access through equity. That's the quality strategy goal. The throughput to that is, if you go over to the second or the third column, increase use of cultural linguistic services for Medicaid and CHIP populations. That's the goal objective. The way we're measuring that is % of hospitals reporting real D and SOG data. Another connection point would be % of hospitals reporting attestation of meaningful language access in calendar year 2023. Excuse me. Another bullet, the second bullet for quality strategy goal would be, for quality strategy goal number 1 would also be increased reporting of real D, SOG for Medicaid and CHIP populations, the second bullet in the first row. Both of those first and second bullets go to quality strategy goal number 1. Quality strategy goal number 2 in the rural QDT type, access to equitable preventative healthcare. That lines to quality strategy objective, third bullet, reducing preventable hospitalizations, which then lines up to the third bullet measure of avoidable ED utilization. That's an example of the first row of rural, and you'll see that they're fairly consistent between rural, DRG, and public academic center. These are what are being proposed in the slate of preprint QDP applications going forward. I think when, Tom? This is the phone a friend.
At the end of September or beginning of October at the latest.
Okay, thank you, Tom. And then as we inform CMS around these particular measures and goals and objectives, I will be updating the quality strategy. Again, these goals and objectives will be in the actual Oregon Medicaid quality strategy that will be posted to the OHA website. Next slide. So we are here now, big old red star. Proposed goals and objectives have been communicated. And then, oh look, I think I wrote by September 30th. So that sounds about right, Tom. So anytime between whatever Tom just said and no later than October 1st or September 30th, we'll be submitting the QDP preprint applications. And then I will also, that's Tom's job. He does the preprint. And then I will be publicly posting the Oregon's Medicaid quality strategy. Next slide. Basically, these two resources, number one, provides guidance about the direct payment program. So literally it's the letter that says, you know, how do you connect the pieces? And then the actual quality strategy toolkit about goals and objectives and having measurable goals and objectives. And then you also have Tom and my actual email contacts. And it looks like we have a question already in the email or in the chat string. So I'm going to stop. I'll go back. Jennifer, you wouldn't mind go back to the table because that's probably where there will be questions. And then I'm going to read the question out loud that's in the chat string. The question that I received is how are we going to, how are hospitals going to be notified about these metrics and connecting these? So Tom and myself are working with the hospitals in regards to these metrics. There's a whole host of things that happen behind the scenes in regards to the Qualified Direct Payment Program. There's the technical aspects of the actual program itself and reporting and the mechanisms. And then there's the quality improvement side of this and connecting it to the broader context of the quality strategy. So the quality strategy part of it, we've been hosting fairly recently meetings with the hospitals and myself, and like, what is this CMS is saying? Like, how do we connect the qualified direct payments to this quality strategy thing? That's been, again, a newer part of the conversation because of the direction that we've received from CMS. So the hospitals have been having those conversations fairly recent with myself just being engaged into the more practical conversation or the regularly technical conversations that OHA has had with the agency. So we actually have one coming up, I think, Wednesday, and we'll start to talk with the hospitals themselves as a group. I don't get on all the technical part, but more on the kind of the implementation part next. On what does it look like with the implementation and the quality improvement side of these metrics, and moving forward, and the coordination and the what does this mean and how do we move back into the CCO parts of this and the care coordination and all those kind of conversations. So that would be a stay tuned now that we're bringing into the broader context of quality. As we bring those two pieces of quality and the partners of the hospitals, the CCOs, into the mix. This is also negotiations. So this is what's being proposed. So we also have to actually get CMS to propose this. And this is all within what's aligned to Oregon's current efforts around, obviously, our 10-year strategic goal of eliminating health inequities and many of OHA's priorities. So this is also what is lined up with Oregon's work. So we have to submit it through CMS as preprint and then obviously negotiate with CMS. So we'll see where that goes. Another question, how does preventable ED utilization evaluate hospital quality? David, you know, going right for the question. It's about, and we were looking at several hospital metrics in regards to like readmission rate, ED, avoidable ED utilization, about trying to, you know, getting people hopefully right care, right setting, and their ability to care coordinate back out. So that's kind of what we're looking at it. We are still looking at a few of those measures. That is the one that we're putting here, but I honestly am still talking to the chief medical officer and our technical analyst who is looking at data. So that's the one that's on this slide, but I know that our technical analyst is looking at the data because I know we also had avoidable readmissions in the last 2020, well, I guess it's 2021 preprint. And so we had a couple different hospital avoidable readmissions and the avoidable ED. And so this is just what put it for, I think we're toying between the two, honestly. So I think it's about the care coordination side of it.
Okay, thank you.
Yeah, hi Lisa, this is Jeannie. And I spoke just because my question kind of dovetails with David's, but I guess I'm curious. So we're trying to get the state ship our quality and our strategy going forward. And I'm assuming that's aligning with Pat Allen's OHA, eliminate health disparities by 2030, right? This is all aligning and we're looking at those outcomes. And yet it just seems if the goal, and I'm going to just pick on number one, but if the goal is to ensure quality and access through equity, and then preventative access to equitable preventative healthcare, I guess I'm wondering, why are we not measuring outcomes in terms of colorectal cancer screening or breast mammograms being done or things of that nature versus hospital ER visits, preventable visits? Why are we, I guess I'm just wondering why we're choosing to stay on that level.
So your question is, again, processing, not fully here, and then my brain head. Your question is, for access to equitable preventive healthcare, why are we not inclusive of going maybe in the more upstream of like mammogram screenings, where hospitals play a role in? That's obviously the setting where you're having those. Is that what you're saying?
Or I guess I'm so the rural initiative has to always involve the hospital. That's the exception that we have, or that's the waiver that we received from the feds. And it has to have something to do with rural hospitals on every level.
There's 4 different kinds of applications,
yeah, I have them.
Let's just call it. Mm-hmm. One of them is rural, and it's very specific to rural hospitals, right?
Well, that's what I'm wondering. Is that specific to rural hospitals?
Yes. So what we're getting approval from CMS for is for a supplemental payment for services in each setting. So and that's the way that we broke them out into different hospital settings. So each payment or all of these payments have to be tied to a service that we can show evidence of a Medicaid service happening in that setting.
Yeah, okay. That's a little more limiting. But yeah, I mean, you could look at the biggest providers of mammogram screenings are probably going to be in hospitals in rural settings. I don't think there's probably as many diagnostic imaging centers as there are more in the cities, in the rural areas where the hospitals probably provide a lot of that service. So you could look at mammogram prevention per se, if you're going to go a little bit more upstream. But anyway, that's probably a discussion for about a year ago when you were looking at the whole thing. So I'll stop diving down my rabbit hole.
No, I appreciate it. I think, Jeannie, the other issue would be maybe a couple years from now. I mean, the other issue is what we heard from the community as the greatest problem right now in the rural is about access to care. I mean, it's like what we heard from some of the committees was about not access to preventive health care. It was just basic access to care for individuals in rural hospitals across certain demographic areas, just being simple. And so that was part of the concern, is to one, align to OHA strategic goals and where our quality goals already are. Number 2, also to listen to the community and what we heard. Any other questions? So the next step that I mentioned again is that OHA would be putting forth some form of these. Again, the avoidable ED utilization versus avoidable readmissions. We're still toying between those two, I believe. But good point, David. But I think it's around care coordination, appropriate care, appropriate setting, that kind of conversation, and what role can the hospitals play in that care coordination. And then I will be updating the quality strategy. I already have. I'll just be posting it by September 30th once we've landed on the academic OHSU ones and the behavioral health, and then that will all get publicly posted. And you'll all hear about that at the next QHOCs as well, and any kind of subsequent quality connection points with the hospitals at this meeting. Thank you very much. Jennifer, if you wouldn't mind circling back to the denial slides, that'd be great. Thank you, Tom. And Veronica, are you on?
Yes, hi. Are you able to hear me?
We are. You have the floor.
All right. Hello, everyone. Veronica Guerra, and I just want to quickly check and see if Tressa Perlicek is on the call as well. I'm not hearing Tressa, so I will just go ahead and we can I can circle back with Tressa if there is anything specific for her team. Good afternoon, everyone. Veronica Guerra, Quality Assurance Manager, and I am here today to talk about overturn denials with you all. You may recognize this conversation for those of you that were a part of the CCO contracts and compliance meeting that passed end of August. We did bring this topic there, and there was a request to also bring it forward to QHOC. So we are here today to have that conversation here. And largely this is a presentation to just make you all aware of some issues that we've been seeing and a process that we will be putting in place. It will basically be kind of a stopgap process to try to get this issue taken care of for our members, and then we will kind of have a long-term strategy to monitor this area going forward. So if we can move forward to the next slide, please. Thank you so much. So just this is a brief reminder of the requirements. And so the requirement that is currently in place is that when there is a denial, so a service denial that is overturned, whether it is by an administrative law judge or the MC itself, so the CCO, there is a requirement that the member receive those services or be authorized to receive those services as quickly as possible, and no later than that 72-hour time frame that you see there. And so there have been, actually, if we can move on to the next slide, there have been numerous instances where we've heard from members that have reached out to a CCO after a denial had been overturned. This is largely, many of the folks that we've heard from have been in instances where there's been a reversal by the administrative law judge. And I apologize, I just realized that I am not on camera. Sorry about that. There we go. We have had several members reach out to us and ask us to try to obtain more information about how they move forward with obtaining access to the service once that denial has been overturned. In some instances, members have had difficulty obtaining information at all. So they may reach out to the CCO and may hear, there have been instances where we've had some folks reach out and they were told that, folks, the staff on the CCO side were unaware that denial had been overturned and didn't have any information for the member. Those are just kind of the situations that we want to just make sure that we're are not happening, right? And that when a member does reach out for that information, that they are receiving the correct information in terms of how to move forward, but also that the CCOs are proactive in reaching out to the members to be able to kind of move them forward in accessing that service after that denial has been overturned. And again, that is whether it's been overturned by the ALJ or by the MCE itself. And so we've done a bit of outreach and support for those members that have reached out to OHA to obtain assistance. And so we wanted to bring it forward to talk to the group about these concerns. And then, as I mentioned, we are planning on putting a process in place to work with you all a bit more closely for a brief period of time to make sure that these denials that are overturned are moving forward and the member is receiving access to the service within that 72-hour time frame, or your I understand that there are some services that just cannot be rendered in 72 hours. I understand that. And we're not, in those instances, as long as there is a good faith effort to show that, the member is being, you're coordinating with the member and you're setting up, you're authorizing that service to be provided at a later date, then we obviously will be taking that into account. Next slide, please. So what we'll be doing, and we talked a little bit about this through contracts and compliance meeting, but what we'll be doing is that there will be some education happening. So just making sure that that we're working through you all. So QHOC representatives and CCO contracts and compliance representatives to make sure that we're providing you with the information about the requirements and what is expected, and that information is being filtered out through your organization. And so we will be including some information in the CCO weekly newsletter. And as I mentioned, we'll also be bringing this back to contracts and compliance to those meetings. And if folks would like to, we can also bring it back to QHOC. And then OHA, as I mentioned, will be outreaching directly to those CCOs. So when the hearings team is notified, OHA's hearings team is notified of a overturned denial from an administrative law judge, they will be reaching out to quality assurance team, and the quality assurance team will be coordinating with the CCO to make sure that the member does receive access to that service within that 72-hour time frame, or you're making a good faith effort to get that service rendered as soon as possible. And so that will be kind of the stopgap process that we'll put in place for a little bit to just kind of help, move, ensure that we're not, that the members are receiving information in a proactive manner, and that they are, being shepherded through the process to obtain access to that service. And so let's see. I think that is all that I maybe want to highlight. Actually, I apologize. There is one more thing, and it's not on the slide here. But I did talk a little bit about long-term monitoring for this. We are looking currently at making some adjustments to Exhibit I quarterly reports so that we can track how many service denials that were overturned do receive access to the service. So the member receives access to the service within that 72-hour time frame. So that will be a future change, but I do want to put that on your radar so that you can know to expect that. And so that will be something that we'll implement for kind of future monitoring to just make sure that we're keeping a close eye on this. And I think that is all I have for you all today. So I'm going to stop and see if there are any questions or any clarification that can be provided. And I don't see anything in the chat on my end, but Lisa, I'm not sure if I'm not seeing it for some reason.
Yeah, hey, this is Jeannie. Hi, Veronica. The chat's not enabled. The only person we can chat with is Lisa. So I see David, Dr. Shute has his hand up. Go ahead, David, you got a question for Veronica, if that's okay?
Yeah, thank you. Just to clarify, is this just applying to cases that go to a fair hearing with an ALJ, or does this apply to all appeals that are overturned?
It applies to all appeals that are overturned. So obviously, we will only become aware of those appeals where there is ALJ involvement. So OHA will only become aware of those. But we do expect you to apply the same process to all appeals that are overturned. And again, the only we'll obviously hear if a member comes forward to us to bring up any issues that they're having with obtaining access to the service, then we'll obviously become aware of there being a potential issue. But we do just want to I do want to just reiterate that you should be applying this across the board to all appeals that are overturned.
Okay, thank you. And then just a comment, most of the services requiring prior authorization are really not available within 72 hours. A lot of those are surgeries, diagnostic imaging, and so it's really not possible to provide access to most things within 72 hours, especially in a rural community.
Yes, and I completely understand that, and that is why I had that caveat in there about showing a good faith effort. As long as the process, so in those instances where, like, for example, maybe you have a surgery, right? Totally understand that, you're not going to get a surgery scheduled in 72 hours most of the time. As long as you show, though, that in our conversation, so Quality Assurance will reach out to your designated staff member, and we will make you aware of the requirement, and then we'll do some follow-up with you as long as you can show us that you're making a good faith effort to kind of move that forward and get that surgery scheduled. For the moment, until there are changes to this rule, that will be enough for us. And obviously, we will want to know when that surgery is actually scheduled for the member. But yes, complete the point taken that
Okay. Thank you.
Not everything can happen in 72 hours.
Hey, Veronica, thank you. Appreciate that. I have another question too about, so the tracking, I'm wondering, how are you all tracking those complaints that you're getting now through the OHA so that you'll be able to follow? I mean, Exhibit I, you can follow and we can report then. But my question is, now you're getting, a number, what a number of complaints are, and it's so hard to know, like, out of the, let's say 10 are overturned, I mean, across the state, 10 are overturned per month. How many calls are you getting saying these aren't, getting done? So I guess I'm just trying to figure out how you're tracking and how you're going to track going forward to know that that is not happening.
Yes. Good question. And so currently the complaints that are coming in are being tracked through our client services unit, or we're receiving through ombuds. So they'll come in through either one of those avenues. and then they'll be referred over to, so in the instance of ombuds, if there is a complaint that comes in through an ombudsman or person, that complaint will then be sent over to HSD, specifically to, we have an individual that on the HSD side and Brown that works on complaints. And so the complaint will be sent over if it is something that, involves Medicaid. And then in the case of client services unit, they also refer anything over to Ann Brown if there are complaints that need to be resolved for members. And then the other place where some of these complaints are coming in are through Tressa Perlichik's team, so the OHA hearings team. They have been receiving, just because they work very directly with members, once a appeal comes forward for a hearing review, they work so closely with members that sometimes those complaints are coming in through that hearings process. And so what we'll be doing is to kind of make sure that we're tracking so every time, as I mentioned, every time a reversal comes in, so a service denial reversal from an ALJ, the hearings team, OHA hearings team, will be forwarding that over to QA. And so we'll have we'll be tracking all of those. And hopefully they don't turn into complaints, because we'll be implementing this process and, kind of moving forward. So hopefully we won't be seeing any more complaints, but if we do, those are the avenues that we'll be tracking through.
Great, thank you so much. And then I think Dr. Hodges has a question as well.
Yeah, thank you. And so I guess I kind of going back to Dr. Schutz's question, and the problem I have here is in the second bullet point, to ensure the service is authorized or provided. I just want to make it very clear that we, the CCO, certainly have ability to authorize, but we have absolutely no ability to provide or force that the service be done within 72 hours. That's completely out of our control. I mean, we're sitting here in the middle of a national anesthesiology provider shortage that is only escalating. Getting surgeries scheduled and done is just way with, I mean, this is not within our ability to really impact in any way, shape, or form. So I don't understand how we're supposed to do the provided part of that, or if we can just stick with or. I mean, we certainly, again, we can do the authorized part, but the providing part is a whole different set of people.
So again, if it is a service that is, cannot be rendered within those 72 hours, then showing documentation that you are at least working on authorizing that service and getting, that in the instance of a surgery, getting that surgery moving forward.
Yeah, but again, we as a CCO don't, we authorize and we can communicate to the provider and the member. That has certainly always been our job and part of our processes, but we don't, then we're done. We can't, that becomes the provider, the surgeon's office, the scheduling, the hospital. I mean, that becomes way out of our ability to influence.
So it is your responsibility as a CCO to ensure that the member receives that service if a denial is overturned. And so that is what we are saying here. So your responsibility is to ensure that that service is rendered to that member. I'm not saying you have to yourself provide that service, because obviously that's not possible. But you do have to ensure that those services are rendered to that member, and that member has the right information to be able to access that service. So that is what we are looking for here. And again, I just want to reiterate, we understand that not everything can be provided within 72 hours. And that is okay, as long as you are making a good faith effort to move forward with connecting the member to that service, and ensuring they have the right information to be able to access the service after that denial takes place, right? So, so I would maybe flip that statement to say, you know, you're proactively reaching out, you're providing information to them so that they know how to access the service once they receive that ALJ decision that reverses, you know, the appeal denial. Your staff is proactively reaching out. They have the right information about how to move forward with receiving that service. And that is what we are looking for. So I'm going to stop there. I see Lisa's hand up. And then if there are any other questions, happy to answer them.
I was just going to build on what Holly Jo was saying, give an example. So, for example, when I was working at OHS Neurology for OHP patients for cerebral palsy, an individual would get denied for Botox treatment that had OHP. It would go through the appeals process. I would have to help the patient through that appeals process. It was often denied. And then that patient for CP, cerebral palsy, would ultimately get the service because, you know, it would win. And then, you know, that particular clinic was booked out 3 months, obviously not 72 hours, 3 months. But that's not your problem as a CCO that we're booked out 3 months, right? It's my problem as the neurology clinic. But all your job was as the CCO was to make sure that the member had the right contact information, that had the right coordination to get their appointment. So your job was to ensure that they knew that the appeal was granted. Your job was to make sure that they had the right contact information to schedule the appointment, and to assure the access of getting the appointment. I believe that was what Veronica is trying to say, you know, in the good faith of getting the access to the appointment. Now, obviously, you can't magically make, you know, that particular provider improve their wait time, because there's nothing you can do about that. And that's not the expectation of OHA's quality assurance team, because that's not, you know, within CCO or OHA's, you know, scope or responsibility or magic powers. There's no easy button to make some of those practitioners, because it's the reality of certain specialties and services. But it is the reality that CCOs are responsible for care coordination, and it is reality to ensure that the members are communicated, because that is your job. And when the member goes, hey, what am I supposed to do? They're calling the CCO to figure out what they're supposed to do. Is that correct, Veronica? That is the expectation, because that's who the member calls, because they call me and they don't know what the heck to do in neurology. And I'm like, I don't know, go call your, I would honestly make them call their CCO regularly. And I'd say, I'm booked out till blank. And they're like, what am I supposed to do? And, you know, they would have to talk to someone in their CCO to regularly get the support and guidance. And that's just the reality, is that support and guidance and communication.
Thank you for that example, Lisa. And that is consistent with what, you know, the expectation would be. And I see Dawn's hand.
Sorry, thanks, Veronica. I'd like to call both of your attention to the really good question in the chat. At what point can we start holding providers accountable for consistently not being available, accessible in a time frame? And what levers do CCOs have with their provider networks? Now, when we are talking about a a limited resource, behavioral health, neurology, there are limited resources. We certainly need to be thinking about that at a systematic level. What we need to be doing to support, be it broadening access to interim services, or looking at it winds up being reimbursed, whatever the other levers are to expand access. I think that's a really good and important question for CCOs and fee-for-service and OHA at the bigger level to be thinking about. And I'd like to hear Lisa and Veronica's response to that, but I'm seeing 12:29 p.m.
I don't have too much to say that I think that would be a really good conversation for QHOC. And you know, my initial thought is that you know, maybe there could be some work to think through potentially either contractual provisions or other information, other quote unquote incentives to get those providers to be more accountable for access to those services within a reasonable time frame, whatever that reasonable is. And so that's my initial thought. And then I think just very quickly, in terms of when does the responsibility end to ensure members have access to overturned services. So for now, the rule, because we have a rule in place, that responsibility will continue until that rule changes. And I'm not sure that we are at this point considering, you know, changing that particular rule, but we can definitely have those conversations here at QHOC or in contracts and compliance to, you know, discuss any challenges that folks are having as we launch this process. I'll hand it over to you, Lisa.
I think there's a conversation to be had. I'm just going from being in a provider and working through these operational details, and working in a specialty provider and working in a primary care provider / behavioral health provider / dental provider. I've worked in all of those settings, and there's a conversation to be had around access. There's a conversation to be had around communication with provider or patient members. I'm happy to provide my insights into that. It'd be a very rich conversation. It'd be a very difficult conversation. I think to Deanne's comment about ensuring something that does not exist in adequate quantity is provided is the issue. And we all know that there's an access issue in any one of those disciplines, primary care, specialty, surgical, you name it, there's access issues across our continuum of healthcare. I think the issue, what Veronica's presenting, is when there's a denial, what is the role of any one provider, the role of the CCOs in ensuring that the communication of the member, ensuring that the member knows what the heck's up and what the heck's not up, right? That's one part of what I think Veronica's speaking to in this rule change, or I don't know if it's a rule change, Veronica, what you just said, but I think part of it is what the member know or not know in regards to this overturned denial, right? You can't change the access or network of requirement. That's not the expectation, and because you can't. There's just not enough providers, or there's not enough anesthesiologists to make the surgeon go do whatever the surgeon needs to do. That's not what Veronica's saying, I don't believe. It's about the communication to the members about the overturned denial, making sure you communicated what the outcome is, making sure they have the right information about how to access those services and what their rights are with those services. That's, I believe, the crux of everything. Now, if those services are 6 months out, if you're talking about neurology, because that's my specialty that I worked in, then understanding to the individual, hey, your overturned denial is, you're approved now, but the bad news is that it's 6 months out, or we have to work through, you know, X, Y, and Z to get you access, right? But that's a conversation of care coordination between you and your member because it was overturned. That's the kind of thing that I believe the agency is expecting between the CCO and the member based upon that overturned denial. And we can talk about that more, which it sounds like it's a much richer conversation. So stay tuned. And now that we're officially over, I think Veronica and I can circle back with Dawn and we can figure out how to bring more of this into a future agenda. Jeannie, and I'll let you field any further follow-up from the CMOs and the quality team. And then you and I can talk in agenda setting, and then Dawn and I will talk with Veronica and we'll see where we take this next.
Yeah, it sounds good. I think that just everybody walking away with the basic understanding that people in general really want to do the right thing, right? Providers want to provide the service. CCOs want to get those members to the service. OHA wants to ensure those services happen. And advocacy is happening on many different levels where, you know, everybody's doing their best. And I appreciate OHA bringing the issue and Veronica explaining it, like people need to get those services if they're overturned. And so we'll get there.
Jeannie, I just think we have two issues here and we can't mold them together or we will all fail. One issue is the communication regarding the overturn of the appeal that lies in the CCO world. And the second is providing the service that lies in the provider world. And if we don't separate those two issues, we are going to set unrealistic expectations for the member that will set us all up for failure.
Yeah, there's a middle though to that discussion. And while it is the provider's responsibility to provide the service, they have a contractual agreement to do so. And to enforce that, we oversee those contracts as CCOs.
That's correct.
So
correct.
we have the ability to work with them to say, hey, this thing was turned over. I see you're super busy. I know you have a payer mix and I know these things are happening. But as a CCO, you have a contract with me and I expect you to provide the service to my member. So there is a balance there. Then this is to me where the CCO has the work to do. We need to be making sure that you're absolutely right. We can't provide that, Holly Jo. Our hands are tied. I totally agree with you 100%. However, we do have contracts with providers and we need to be able to work with them and say, hey, help us out. And we have tons of providers that want to do it. We just have to figure out how to get our members into them and how to support them to provide those services. So you, me, all the rest of our partners here, we have to provide
all of that, but I'm just thinking that the unintended consequences of this is that those contracts will slowly go away or quickly go away.
Having just worked, I'm hoping that's not the case, but having just worked through a corrective action plan with the state and Veronica's team, they were very reasonable when we showed our good faith effort to make those changes with our providers and show that. They were very reasonable and said, hey, we see you are reaching out, you know, show us this documentation, show us what your barriers are and how you're working through them. So I think and reasonable. So I think, I don't think, I mean, I agree with you. Language is everything. And we cannot provide the service in a sense of those services, but we need to oversee those contracts. So I see your point, Holly Jo. I totally get it. And we can't be held.
We're dealing with a provider population right now that is at the end of their rope and asking them to do one more thing. I just worry will really push them
We're
away.
Not asking them to, I'm hoping we're not asking them to do anything outside.
You're not going out there and asking them to do a service within 72 hours. I think that is not.
Definitely not.
Please, as a former provider office, if you all
we definitely can't do that.
That literally just makes my blood pressure just raise.
It makes all our blood pressure. That's why I fear that
you have an expectation
needs to be clarified.
To services to members and communicate those services. You have levers as a CCO that we can have an exploration conversation about how you move providers and one of the comments earlier about how do we hold accountable to providers these services. We're not even going there yet because there's different barriers for providers even in having these services, as in there's fatigue, there's actual provider issues, you know, as in we don't have enough. There's a whole host of things. That's not what Veronica is saying through this conversation either. So that's another conversation that we can have, not now.
Yeah.
But we will.
I hear you, Holly Jo. There's no way we're gonna. we're not going to be able to push that forward. So Lisa, I think you're right. Let's take it offline to the next, to a different setting.
You field from your CMOs. Dawn and I will chat with Veronica, and we'll carry this topic yet again.
Yeah.
For those that are coming back at 1 for the TQS peer learning, I will see you then. Thank you, Jennifer, for opening up the chat string. We'll try and remember to do that again for it should be open for each QHOC. Thank you for getting that reset up this time around. Have a good lunch, everyone, and I'll see some of you back here in 20 minutes. Thanks, Jennifer, for advancing a slide. Laura, are you on?
I am on. Can you hear me?
I can hear you.
I guess I should turn on a camera. Oh, if I turn on my camera, it's going to look at a wall.
Well, then maybe don't turn on a camera.
Totally forgot about that part.
We don't need a camera. We don't.
Today's the first day back from vacation, so I'm still acclimating.
Okay, then we won't have you turn on your camera if it's just facing a wall. So hello everybody, welcome to the QHOC Quality Performance Improvement Session. I'm Lisa Bowie. I go by she, her, hers. We are going to get right into it. Laura Matola, who is going to be off camera because her camera is pointing to a wall. She is with she's your QHOC chair. Laura, do you want to introduce yourself?
Hi, I'm Laura Matola. I'm the Director of Compliance at AllCare CCO.
We're going to go ahead and do a few announcements, and then we're going to get right into the agenda, which is the Transformation Quality Strategy Peer Learning session. So let's see here. I do have a few announcements. We'll go ahead and do a couple housekeeping. The chat string has been turned on. It should allow everyone to chat to each other. It wasn't turned on that way in the morning session, so we turned it on midway. So it should be turned on now, so anyone can chat to each other. When you are speaking, if you wouldn't mind just raising your hand, or you can put it in the chat box. Just as a reminder, you can also have live transcription and or closed captioning. And if you wouldn't mind when you do speak, just to say the name and organization you're from, that'd be great. A few announcements before we get into the TQS slide deck. Let's see here. Maybe last week, I think it might have been Thursday, maybe Friday. CCO quality staff would have received from Health Services Advisory Group, HSAG, the External Quality Review Organization for OHA. You would have received your statewide performance improvement report back on your mental health access integration statewide PIP external quality review. So y'all submitted that on July 31st. This is the initial report findings back. There is an opportunity to update and seek any clarification. You will notice in that response back from HSAG from your initial submission that many, and I think many, maybe all of you may not have noticed in late July, possibly, I think on like July 27th, don't exactly quote me on the exact date, but maybe July 27th, maybe July 28th, OHA released the mental health access statewide PIP data. We had submitted data to you all, but we updated data. Jason Slack, the analyst, uploaded data that July 27th, July 28th date. I sent an email. It looks like maybe many of you didn't use that updated data when you submitted your July 31st external quality review statewide PIP report. So you might have noticed in your findings that you just received last week that discrepancy. So please make note of that. And if you don't have access to that July 27th, July 28th updated mental health access data set, please reach out to Kristen, myself, or Jason, and we will make sure you have that. But it was released through the secure file transfer portal of your CCO dashboards sometime between that July 27th, July 29th, July 27th, July 28th date. And it looks like many of you maybe did not include or reference that data set in your submission, and that probably needs to be reconciled. Questions about the mental health access EQR reports that came back to you all from HSAG last week? Jenna.
Hey, Lisa, thanks for bringing that up. We were planning on addressing or asking some of these questions in the technical assistance calls, but I think it might be helpful for all CCOs to maybe hear the answers. So because we got those data sets late July, many of us were already kind of we'd already done our baseline and our intervention work and our root cause analysis and all of the QI work leading up to that. And so I think I was a little confused as to how that data set was supposed to inform work that we had already previously done. So we had already developed a lot of the data infrastructure prior to that July date. And that's really what we spoke to is the data that we used to do the root cause analysis and developing of the interventions and all of those pieces. And so I'm trying to understand how to make that connection, just given the timing.
I think there's a part of it where your report, I think one thing that we want to, there's part of it where you're reporting the actual data. The measure itself has to be the statewide one that we provide, because consistency across the CCOs using the statewide one. And then your interventions and your CCO specific data where you're developing your interventions, there's a spot where you can reference your own data and how you develop the interventions based upon your own analysis and your own data sources. I think you can report that as well. And I think the question, Jenna, to like, where do you report the one that's OHA's data, the statewide indicator, which is, quote, the OHA data, that's where you need to report the one that's the July 27th, 28th file. And then the interventions, the ones that were specific to CCO specific data sets, I guess you could say, that's a different section as well. So, and this can also come up, and HSAG, Chris Hartman, Christy, Dawn, and Tom, they're more than happy to hop on a technical assistance call to walk through where within those forms that you'd reference that. But I definitely want to make sure you all heard the statewide indicator is the one from OHA's data set, and most likely it just got oversighted when we uploaded the revised data set because of something related to, I can't remember, enrollment gap. That's why we had to upload the data, the new data.
Great, thanks for that clarification.
And that's again related to the mental health access one. I don't have any update for the SUD statewide PIP design stage submission, so there's no new news there. Ginger? Looks like Ginger maybe took her hand down. Okay, I'm going to go ahead straight into the TQS peer learning session. Let's go ahead and go to the next slide. Thank you for those that have joined now. So the agenda, how this is going to work, we did this last year. There will be 3 breakout sessions this time around. I'll do just a quick brief overview, and we're not even going to go for the 5 minutes because you all are pretty familiar with TQS by now. We'll kind of talk through the breakout learning instructions, and then we'll honestly just let you go into the breakouts. Next slide. The actual submissions have been posted on the web, so the actual CCO submissions are out there. I provided the link there. Some CCOs have provided handouts, and those are in the meeting packet. And the meeting packet is posted on the actual website. I will drop the actual QHOC website here in the chat shortly. And then if any other CCOs have any handouts they want to provide, then they can drop that in the chat, or they can email it to myself and I can get it out to this distribution list. Next slide. Okay, for the breakouts, each breakout room will have 2 CCO projects. There's a kind of a, I guess you could say, a CCO lead that will provide a brief project summary. And that point of contact will kind of just provide that brief summary. And then it's really just an open dialogue about amongst those participants in that breakout and the CCO point of contact. Next slide. Here are the breakout groupings. So there's 6 rooms, real advanced here, room number 1. And so when you see the actual breakout, which it's really self-selection. So those that are on this call right now, I'll hit a button in the magic of Zoom and electronics. It's, you know, so if we were in a room, I'd say break, and you guys go to like a little table and there's a sign. Well, here I'll click a button in Zoom and the breakout room will start, and it literally says room number 1, and it says Shin non-dual, because basically it's by the TQS component. But what you'll see is room number 1 has advanced health and health share in it, and it has the 2 TQS projects, medical shelter program and emergency department pilot for members with substance use disorders. So whoever are the points of contact for health share and advanced health, please make sure you go to assigned room number 1. So obviously, if you are a point of contact for your CCO, make sure you definitely know your room number, because yeah, you need to go for sure to your room number. Everyone else gets to self-select your room number based upon which topic you're interested in learning more about. Then, so you're looking for the room number and or the TQS component, which is the 3rd column on this slide. What I'll do is I will basically leave this screen on for just a second more. And then what will happen is I'll select, I'll click the button and the breakout room will pop up, and you just pick which room you want to go to. So it's self-selection. You'll be in that breakout room for approximately 25 minutes. I'd encourage you to at least introduce yourself and your organization, and then the points of contact for each CCO to, again, present their particular project, brief overview, and then begin the dialogue. So I do brief introductions of who's in the room and name, title, name, organization, and pronouns, and then let the points of contact present, and then open dialogue. Again, you'll have 25 minutes, and then what will happen is you'll come back out. So we'll close that breakout room. You will come back, you'll zoom out, you'll be here again. This screen will be up, and you go pick a second breakout room. Then you go back, you zoom into a different room. Same thing happens again. You come back, and then you go pick a 3rd room. So you get basically 3 opportunities to learn about 3 different projects. Any questions before I let you zoom away?
And just a reminder, CCO points of contact for your projects, stay in the room, the room that you start in, so you can present to everybody that comes.
Yeah, points of contact, sorry, you don't get to go learn. You get to stay and speak the good work of your CCO. And at the very end, we'll just kind of do a large group wrap up, but it will be for whoever wants to speak up, but very informal. Okay, I'm gonna click the magic buttons. Open all rooms. I think you can all go. think that worked?
I need to get to room 6. How do I get to room 6? Anyone? Should be the oral health. Okay. I see someone.
I'm just going to try to help you. I don't know if I can or not. Assign, let's see, allow.
Sounds like it's oral health integration one. So let me. Oh, I see it. I see it now.
Do you see it?
I think I got it. Yeah.
Great. Okay.
Hey, Lisa, can you hear me? Or this is. Can anyone hear me?
Yeah. Hi, Stacy. I can hear you. This is Jennifer Bowen. I help.
Hey, thanks.
Support
I
this.
can't.
So.
Awesome. Thank you.
Okay.
I don't have an option to get into my room that I'm supposed to be presenting in room
Do you know?
1.
Do you know which one it is?
Yeah, it's room 1. It's room 1.
Do you know the name of it by any chance?
The medical shelter. What?
So I've got the SCHN non-duals, the SDOHE, the SPMI. access and class, health equity data, oral health integration.
It looks like room 1 is SCHN non-dual, special healthcare needs non-dual.
Okay, I will put you there, I guess, if I can.
Well, I see a join button for that one. Let me try that.
Okay, all right.
Thank you so much.
You're welcome.
This meeting is being recorded.
We're done with the breakout. Thank you all for coming back. That's just lovely. How we were going to just use this time when we gathered back from the breakout sessions just to do kind of a large group report out and just see how the breakout sessions went. I know I popped into at least one of the breakout sessions. I did have to step away for a different meeting, but I was able to come back. And I know some of y'all had slides. So for those that did have slides or handouts, again, if you want to email it to me, then I can add it back to the packet and or distribute it so people have access to it. That'd be great. We will update. Either way, I have to update the QHOC packet from this morning's slide deck. So we'll be updating the materials either way so that it's accessible. Then please do that. But anyone who wants to raise their hand and just kind of give their thoughts on what they learned or what information they heard in their breakout session that was cool. Or talk about Godzilla. No, probably should keep it around the quality or transformation for Medicaid. I mean, you could probably relate Godzilla to it too as well, but you know, go for it.
Lisa, this is Jenna. I think I'll go. I think I always enjoy these sessions because it feels like a really collaborative space where we can say, yep. And I think Emily on our team used the word analog. So we're able to see, okay, we're on the right track. Other people are doing the same thing we are in these spaces. And so there's some comfort in knowing that we are doing the transformation work in a way that, you know, others are thinking. And we also get to hear about the different angles and ideas and strategies that people are using and incorporate that into our working plans. And so I really appreciate just that collaborative learning space. And I know that that's kind of what the title of this space is, but I just really appreciate that because we don't get that as often. Usually it's contractual, here's the things you have to do, and then figuring out operationally how to do it and feeling like, oh shoot, am I doing this the right way? And so transformation work can be really enjoyable when we're in this space together.
Thank you. Caleb?
Yeah, so I came from the SPMI breakout room, and one of the things my counterpart said towards the end, Karen Weiner, was how she noticed both of our projects were focused on expanding and promoting non-traditional healthcare methods when it comes to the SPMI population, and how kind of interesting, you know, and unique that was to see how positively those non-traditional methods were impacting such a vulnerable population. And she's an LCSW, so she's coming to that from a much more knowledgeable point than I am. But I thought that was interesting, looking, you know, that's the whole point of something like the TQS, is looking to transform healthcare beyond what it's traditionally been. So yeah, really appreciate the opportunity to come and learn from our peers about what's going on in the state.
Thanks, Caleb.
I was going to say, I'll make a non-Godzilla comment about room 2. I have to say that the insight that EOCCO showed in setting up their Veggie RX program, and the depth at which they set it to saturate their entire market, as opposed to being focused on a smaller subset of the population, is so great. Because if anybody hadn't heard Marcy's insight on the topic, essentially they're giving food to everybody that needs it, and so they survey the whole community through various providers that act as prescribers. It's such a great idea, but by partnering with prescribers, with CBOs and agencies in all of their communities, they're getting the community used to asking and answering that question of food insecurity. It's not just a question on the HRA for OHP members. It's not just something targeted at a small population. It's everybody. And everybody in their community is getting used to having that question be something that they look at. And that's going to make transitioning into the SDOH metric next year so much easier. Marcy's been doing this for 4 years now. Her community's ready. Like, I just got to give huge props to EOCCO for not letting a food insecurity measure, like transformative work, be small. Thinking big, making it big, is laying huge groundwork for doing other things, and I gotta give props.
Thank you very much, David. I appreciate that. I love giving talks like this, but not just as this is being a, like a I said and then you said and then, but I listened to David's presentation 3 times because we were in the room together doing the presentations. And a couple of the things that I really appreciated was him talking about he talked about housing, and that they are already building out projects that will be ready when the funding is available. So anytime that funding comes up, they're going to have a project that's ready to go that they can say, okay, this funding is perfect for this. Let's move it out the door. That to me is really great, because I think that's something that I can commute then to my housing coalition and talk to them about having these projects in the queue ready to go, so that when funding comes available, we can just move on it immediately. So that's something that I really appreciated about being able to hear the same thing 3 times. It was helpful.
Many thanks. Yeah, room 2 was a lot of fun.
Well, apparently so. Y'all had a good time. Did you guys did you like having the 3 breakout sessions? I mean, right amount of time. Feeling good with that? Thumbs up, the clappy reactions. Felt good.
I definitely, this is Marcy, and I definitely got it at the end, like that we're supposed to come back and go back. But I think maybe a little bit clearer at the beginning that, that you're going to let us know when our time is up, and that we'll automatically move back to the main room, and then we'll re-choose back. I think there was a little bit of confusion, especially in our first breakout room, as to, do we go back? Do we stay here? What do we do? But that's the only thing that I think I liked having the 3 sessions.
3 sessions was great. The timing, to Marcy's point, the timing did get a little bit frustrating, and it was a little bit to figure out.
Okay. Any other topical things you guys liked having? Any lessons, any other great projects people heard about? Do it again next year, obviously. Yes, no, maybe so. Head nodding. Laura, your chair says yes. Your previous chair says yes. Thumbs up from nuns. Okay. Well, then, for the good of order, we will, I don't know what we have teed up for October, Laura. Do you recall? I don't know. Memory's failing me right now.
I don't, but I can look it up and see if I have it written down.
Well, let's do this. If you have an idea, email it to Laura, because we'll be meeting here shortly in our agenda setting call. Because I don't recall right at the moment that we had something teed up.
The one that I have that's listed for October is actually one we actually did today.
So then definitely email Laura your ideas.
Please.
Thank you. I do hope my migraines we hope they will be under control here soon. I may or may not be at the October meeting. That would be another linchpin conversation, Laura. So it could be more quality assurance focused, but definitely we'll connect with the Veronica's team and Carrie.
Got it.
And you all have a good afternoon. I will update, like I said, the meeting slide deck for sure. And anyone that sends me any other TQS slide decks, if they have any or handouts, I'll get those updated as well. So let me know if you have any questions, but everyone else, if there's anything else, just connect by email.
Thank you, Lisa.
Thank you for all those point of contacts for presenting.